I am Dr. Ajay. Today we will have a discussion on the previous year FMGE question papers. As we know, in a FMGE there will be around 10 to 15 questions from ENT, okay, and out of the 10 to 15 questions most of them will be a one liner and a repeaters, not much of it will not be much difficult, and it is one of the easiest thing to answer. As a FMGE exams is supposed to happen by this month end, okay, it is our duty to go through the previous year question papers also. Okay. So, in this chapter, in this topic now, we will discuss about the FMGE questions of ENT which was asked in December 2019. Okay. Obviously, your questions from the ENT subject, I am not sure about the medicine or the surgery, from the ENT subject it will be a simple one, do not worry about it, and it will be more of a repeater and a one liner. Sometimes they will ask some history based, some scenario based, some case based, but most of the time it is mainly a one liner. Okay. So, we will go through the previous year question paper, okay, and as he said there will be around 10 to 15 questions every year. This is just a recall paper. Okay. So, the first question which was asked from the ENT aspect is the most common cause for malignant aorta dissection. And one more thing, in your FMG exam they will be pointing on one topic, and not only in FMG, even in NEET exam, if they pick up a chapter they will point some 2 or 3 questions from the chapter also. That is the exam setters psychology. Okay. So, last time also this happened the same. Okay. There was many questions from the nasopharyngeal carcinoma, there were many questions from the CSF rhinorrhea, and hopefully they are easy questions. So, not much difficult. So, do not worry about it. Okay. The first question which was asked was the most common cause for malignant aortitis externa. So, what is the answer? The most common cause for malignant aortitis externa. So, what could be the answer? What could be the answer? The malignant aortitis externa, the answer is option D. The answer is option D, that is Pseudomonas. Okay. So, what is malignant aortitis externa? Is it a malignancy? So, I will go in depth about some topics which were asked previous year, since they may come as a repeater also. This time the question may change, the options may change, but the topics may be the same topic also. So, I will go in a bit depth about the topic. What is malignant aortitis externa? Is it a malignancy? Is this a malignancy? Obviously no. The malignant aortitis externa is a infection of the external aortic canal. So, which part of the external aortic canal? Again it infects the bony part of the external aortic canal, So, what are the clinical features in a malignant aortitis externa? The clinical features, they may give you the patient usually a uncontrolled diabetes mellitus. Okay, he is uncontrolled not a normal diabetic, he is a patient on uncontrolled diabetes mellitus or a immunocompromised patient, something on a immunocompromised status, maybe on a chemotherapy or maybe on some other drugs, okay, immunosuppressing drugs, okay, immunocompromised or uncontrolled diabetes mellitus patient presenting with severe ear pain. That will be the classical history. The patient will come to you with a severe ear pain, okay, and on examination we can see presence of granulations along the bony part of external aortic canal. So, when I am seeing I could see the presence of say assume that this is the tympanic membrane and this is the external aortic canal, okay, I could see some presence of granulation along the bony part of the external aortic canal. Okay. So, granulation along the bony part of the external aortic canal, okay, and as we know this infection is caused by which organism? That was the question asked. Caused by which organism? It is caused by Pseudomonas. Okay. So, it is a Pseudomonas infection occurring in the bony part of the external aortic canal. And why it is called malignant? As the infection starts here, the infection is in the bony part. From here the infection may spread through the temporal bone. We know that the bony part of the external aortic canal is the temporal bone, right, is in the Peters part of the temporal bone. So, the infection spreads along the temporal bone, and now the infection may go and involve the base of the skull. So, it is called as skull base osteomyelitis. Again a very important MCQ, it is also called as skull base osteomyelitis. So, it can go and involve and infect, okay, and infect the skull base. Okay. So, it is called as it is more dangerous, it is called as malignant. okay, and it involves the external artery canal, so it is called as otitis externa. So, the organism producing this is a repeated MCQ, that is Pseudomonas. The next question what they will ask is, what all the Pseudomonas infection which can occur, what all the Pseudomonas infection which can occur in the external artery canal. Okay. The Pseudomonas infection which can occur in the external artery canal. What are the Pseudomonas infection? One thing as we discussed, the malignant otitis externa, one is malignant otitis externa. What are the other condition? Other condition, there is one more otitis externa caused by Pseudomonas again, that is diffuse otitis externa, diffuse otitis externa, okay, and another one condition, perichondritis of the pinna. So, these are the three conditions which can produce, okay, which can be caused by a Pseudomonas infection of the external ear. We are dealing with the external ear, not the middle ear. Okay. In the middle ear, as we know, the Pseudomonas can cause a chronic suppurative otitis media, but in the external ear, these are the three most common conditions: the malignant otitis externa, diffuse otitis externa, and the perichondritis pinna. Okay. A very important MCQ, never forget this. Okay. So, coming back to the question, malignant otitis externa is caused by Pseudomonas aeruginosa. So, Staphylococcus aureus causes what kind of infection in the external ear? In the external ear, what kind of infection the Staphylococcus aureus produces? It causes, again an important MCQ, it causes furunculosis. So, furunculosis is caused by Staph aureus, Staphylococcus aureus, a very important MCQ. Okay. So, this is a repeated one also. Okay. Fine. So, coming on to the question number 2, the second question, which of the following pairs of muscles help in opening and closing the Eustachian tube? So, again a very simple question, very simple question. So, for this what we want to know, what are the muscles of Eustachian tube? So, what are the muscles of Eustachian tube? What are the muscles of Eustachian tube? The muscles of Eustachian tube, the main muscle it is tensor vale palatini. Okay. This is the main muscle of the Eustachian tube. Okay. So, the other muscles are the levator vale palatini, okay, and salpingopharyngeus. Okay. So, three muscles which are very important, one is the tensor vale palatini, levator vale palatini, and the salpingopharyngeus muscle. These three are very important. Okay. So, the tensor vale palatini is the main muscle of the Eustachian tube. Okay, what is the function of the tensor vale palatini muscle? What is the function? The main function is opening or closing. What is the main function? So, we know that the Eustachian tube will be open or closed normally. Normally, the Eustachian tube will be closed. Okay. Whenever we open our mouth, whenever we chew, the Eustachian tube will open. Okay, while yawning, while chewing, okay, then only the Eustachian tube has to open. So, the main muscles for opening the Eustachian tube is the muscles which I mentioned here. Okay, the tensor vale palatini, levator vale palatini, salpingopharyngeus muscle. Okay. So, coming back to your question. So, what are the following pairs of muscles which are involved in opening and closing the Eustachian tube? Okay. So, is there option? Yes, the option is answer B, the tensor vale palatini and the levator vale palatini muscle helps in opening the Eustachian tube and closing the Eustachian tube. So, will there be palatopharyngeus here? As I said, the salpingopharyngeus is concerned with the Eustachian tube function, but palatopharyngeus is not concerned here. The palatopharyngeus, what is palatopharyngeus? What does a palatopharyngeal form? It forms the sphincter of Willis. Sphincter of Willis is the boundaries. Palatopharyngeus, sphincter of Willis, it forms the, so we know that the palatopharyngeus forms which pillar of the tonsillar fossa? It forms the posterior pillar, right. So, not to go deviating from the topic, it forms the posterior pillar, it is not related to our area in the Eustachian tube. Okay. The tensor tympani is a muscle of, okay, tensor tympani, it is a muscle of middle ear. Okay. And again it is there in the Eustachian tube also, it is a tensor again, but the main function is by the tensor vale palatini and not by the tensor tympani. Okay. So, the answer is, and the styloid, genioid are not associated here. Okay. The answer is tensor vale palatini and the levator vale palatini. Okay. So, coming on to Question 3. Okay. So, there were 3 questions from nasopharyngeal carcinoma last year, 3 questions. Okay. So, we will go a bit depth in it. Okay. The most common presenting complaint of a nasopharyngeal carcinoma, the most common presenting complaint of a nasopharyngeal carcinoma. So, what is the answer? What is the answer? Is it option A or B or C or D? What is the most common presenting complaint? Most common presenting complaint? The answer is it is a neck node. Even though it is a nasopharyngeal carcinoma, it is a nasopharyngeal carcinoma involving the nasopharynx, okay, involving in this nasopharynx area. Okay, there is a, I am drawing a picture. Okay, the carcinoma is here. Okay, even though it is a nasopharyngeal carcinoma, we know that the nasopharynx area is very rich in lymphatics. Okay, very rich in lymphatics. So, what happens here? What happens here? Even we know that what is the site of origin of nasopharyngeal carcinoma? Again, we need to have in mind, that is again a repeated MCQ. The site of origin of nasopharyngeal carcinoma. Where it arises? Okay, this is a picture of nasopharynx. Nasopharynx. This is a eustachian tube. What is the site of origin of nasopharyngeal carcinoma? It is the fossa of Rosenmuller area, fossa of Rosenmuller. So, where is the fossa of Rosenmuller? Fossa of Rosenmuller. Okay. So, where is the fossa of Rosenmuller? It is usually a hidden area which lies behind the, it is a hidden area, not seen. Okay. It lies behind the eustachian tube, this is the eustachian tube. Okay. It lies behind and posterior to the eustachian tubal orifice. Okay. So, again as I said, it is a hidden area. So, what is the significance with the hidden area now? It is a hidden area which is rich in lymphatics also. The nasopharynx is rich in lymphatics. So, even a small growth in the nasopharynx, in the fossa of Rosenmuller area, there will be communication with the neck node. Okay, so the patient initial presenting symptom will be the cervical lymphadenopathy. That will be the first presenting complaint. The first presenting complaint will be a cervical lymphadenopathy will be the first presenting complaint. Okay. So, this is very important. The patient if it is advanced stages, he may present with a nasal obstruction or epistasis whatever, but anosmia is not here. Okay. But the first initial presenting complaint is the neck node. Again a repeated MCQ. Say in a FMGE, as I said, there will be many repeaters in ENT. Okay. So, hopefully we hope that there will be NPC in the exam also. We will see NPC this year also, they will ask. Okay. So, the most common ideal presenting complaint will be a cervical lymphadenopathy. So, coming on to the next question, Epstein Barr virus causes. Again Epstein Barr virus causes, as I said, the examiner mindset, if he tries to set a question, he may be constantly repeating the same chapter again and again. Okay. So, Epstein Barr virus again is a juvenile nasopharyngeal angiofibroma caused by Epstein Barr virus? Obviously no. It is a benign tumor, but it is not caused. Nasopharyngeal carcinoma? Yes. The nasopharyngeal carcinoma is caused by nasopharyngeal carcinoma. It is a benign or a malignant one. The nasopharyngeal carcinoma, it is a malignant tumor. Okay, but there is a significant correlation with the Epstein Barr virus. So, it has a viral etiology also with the Epstein Barr virus. Again a very important MCQ. Epstein Barr virus, does it cause a rhinoscleroma? Does it cause rhinoscleroma? The rhinoscleroma is caused by what is the organism? It is caused by Klebsiella rhinoscleromatis, Klebsiella. Okay. Stewart's granuloma is again a T cell tumor. Okay, it is not an infective one, it is a T cell tumor. So, here the nasopharyngeal carcinoma, it is a malignant one, but it is associated with the Epstein Barr virus. Again a very repeated MCQ, Okay. So, Epstein Barr virus causes a nasopharyngeal carcinoma. It also causes other condition, as you will be discussing that in your microbiology chapter, but in our ENT, okay, one of the most common causes of Epstein Barr virus is associated with the etiology with the nasopharyngeal carcinoma, very important one. Okay. Coming on to the next MCQ, again with the nasopharyngeal carcinoma. Okay, it is not in the same order as I write. Okay, it will be shuffled, but there were 3 questions from the nasopharyngeal carcinoma as per the recall. Okay, the most preferred treatment modality for a patient with the nasopharyngeal carcinoma. So, what is the most preferred treatment? Now, the patient is a nasopharyngeal carcinoma, he is a cancer patient. So, for a cancer patient we have 3 treatment modalities, either a surgery or a chemotherapy or a radiotherapy or a combined chemoradiotherapy. Okay. So, what is the ideal treatment for a nasopharyngeal carcinoma? What is the ideal treatment? So, now the tumor is in the nasopharyngeal area. Now the tumor, okay, now the tumor is sitting in the nasopharynx area. Okay. What is the ideal treatment here? And again it is a malignant tumor. It is a malignant tumor. It is going and even involving the skull base. It is involving the skull base. Okay, it can even involve, it can, once it goes into the skull base, it can produce multiple cranial nerve palsies, as it is very important to know the spread also. Okay, so it can go and produce multiple cranial nerve palsies. So here for an nasopharyngeal carcinoma, usually surgery is not preferred. Okay, the ideal treatment for an nasopharyngeal carcinoma, is usually a radiotherapy, right. So, but the radiotherapy again has some side effects, as we know, since if we are giving radiotherapy in this area, we know that there is a spinal cord here, there is a brain here. So, we are exposing to some dangerous areas. So, nowadays that radiotherapy is called as intensity modulated radiotherapy, IMRT. IMRT stands for intensity, have this in mind, very important question, intensity modulated radiotherapy, a recent one also. Okay. In this, in a radiotherapy machine, we are just fixing the intensity, we are fixing a 3-dimensional depth and the size of the tumor, we are aligning it in the computer, so that the radiation is delivered only to the tumor area and not to the surrounding areas. Surrounding areas, as we know, for a nasopharyngeal carcinoma, we have vital structures, the spinal cord is there, the brain is there. So, we are delivering the if we deliver the radiation to the spinal cord, okay, what will happen? The patient will have a sign, again that is important, that sign is called as Lermite's sign. Lermite's sign is nothing but when you deliver a radiation to the spinal cord, the patient will feel some tingling sensation in his fingers, some electrical shock like sensation in his fingers, electrical shock like sensation in fingers. Okay, that is called as Lermite's sign, that is following a radiotherapy to a spine. Means we are not giving to spine, the radiotherapy is going and involving the spine, that may produce a Lermite's sign. So we are delivering a intensity modulated radiotherapy, but one more thing is, nowadays there is a role of chemotherapy also. Okay, so the ideal treatment is when they give an option, when they just give radiotherapy or a chemotherapy or a surgery in option, it is better to take a radiotherapy. Okay, but if they give a combined chemoradiotherapy in the option, then that will be the answer. Okay, then the ideal treatment is a chemoradiotherapy and not a radiotherapy alone. Okay, so the ideal treatment nowadays, what we are preferring is radiotherapy along with the chemotherapy. Okay, a chemoradiotherapy. But when they don't give a chemoradiotherapy and they give just a radiotherapy, chemotherapy, surgery or observation like that, the ideal treatment is a plain radiotherapy. Okay, chemotherapy is in no way superior to radiotherapy, radiotherapy is always superior. And surgery, why we are not preferring surgery in this cancer? The site of approach is very difficult. Say for approaching the nasopharyngeal carcinoma, we need to open part of the face and then elevate it and then approach the nasopharynx. Even though we pass an endoscope, we can remove the structures in the nasal cavity area, but not in the skull base area. Okay, so and again we are dealing with a tumor now. So we need to give a proper clearance. So surgery is usually preferred as the last stage of treatment. Last stage of treatment for a nasopharyngeal carcinoma, that is usually preferred is a salvage surgery. Salvage surgery is even after radiotherapy, the patient presents with a nasopharyngeal carcinoma, then go ahead for a salvage surgery. Okay. So this is regarding nasopharyngeal carcinoma is concerned. Okay. Coming on to the next question, yeah, that was a clinical scenario question. Okay. A 20-year-old female, she presented in OPD with a throat pain, okay, and a difficulty in swallowing. So throat pain, difficulty in swallowing. On examination, her right tonsil was found to be congested. Right tonsil, there was a congestion, okay, and the congestion and also the uvula was pushed to the opposite side. That means the uvula is pushed towards the opposite side. Okay, that means the left tonsil was normal, what could be the diagnosis? That means the tonsil is congested and enlarged, okay, the right tonsil alone is congested and enlarged, okay, and it is such that it is also pushing the uvula to the opposite side. What is this condition what I have drawn now? What is the condition with what I have drawn now? The quinsy, peritonsillar abscess or quinsy. So, what are the conditions which can produce with unilateral tonsillar enlargement? Unilateral tonsillar enlargement, we need to have in mind of peritonsillar abscess. Okay. And one more diagnostic criteria which they have given in the question is the uvula has been pushed to opposite side. The uvula pushed to the opposite side because of the pressure effect, have in mind of a peritonsillar abscess. Okay. But in this scenario just for ruling out the other options, okay, will a retropharyngeal abscess present with the unilateral tonsillar enlargement? Obviously no. Retropharynx is behind the pharynx. Say this is the pharynx, the area behind the pharynx is the retropharynx. Okay. So, retropharyngeal area will not present with the, how will be the retropharyngeal swelling? Okay, it will be presenting with the tonsillar fossa will be normal here. Okay, the retropharyngeal swelling will be presenting as a swelling in the posterior pharyngeal wall. Okay, the patient with the retropharyngeal abscess again will present with the swelling in the oropharynx, but here the swelling will be in the posterior pharyngeal wall and not involving the tonsil, that is retropharyngeal space infections. Okay. So, ruling out the other option, so it should not be retropharyngeal abscess. Acute parenchymatous tonsillitis, can it be acute parenchymatous tonsillitis? So, in acute parenchymatous tonsillitis, the picture is, okay, there will be bilateral enlargement. Usually there will be both sides tonsil will be involved. It is not that only one tonsil is involved. Okay, both sides tonsil involved. Then it is a parenchymatous tonsillitis. Okay, again it will be congested as given the question, but it will be both side involved in acute parenchymatous tonsillitis. Okay, so what is the, so the answer is not B. Okay, ruling out option D. Can a parapharyngeal abscess, this is an important differential diagnosis. Okay, can a parapharyngeal abscess present with a tonsillar enlargement? Okay, so what happens here? How will be the parapharyngeal space infections? How will be the parapharyngeal space infections? Say, okay, the picture of a parapharyngeal space infection will be almost similar to that of a peritonsillar abscess. So here what happens is we know that this is pharynx. This will be the parapharyngeal space, right. So, parapharyngeal space is lateral to pharynx. Okay. So, what happens here? Say if this space is getting infected, we know that the tonsil is here, right. If this space is getting infected, say there is infection in this parapharyngeal space, what will happen? It will push the tonsillar fossa medially. So, how will be the clinical picture is now the entire tonsillar fossa itself is pushed medially. Okay, the tonsillar fossa, the pillars which are here, the pillar will come here, the tonsillar fossa along with the tonsil is pushed medially, the uvula again is pushed to the opposite side. Okay, am I clear? I am just erasing it, I am putting it here. Okay. So, as I described, there is an infection in the parapharyngeal space which is pushing the tonsil medially. So, the tonsil which should be here is pushed medially, so that the tonsillar fossa is here and the tonsil is being pushed medially. Okay, there can be congestion in the tonsillar fossa also, and even because of the pressure effect the uvula may also be pushed to the opposite side. But one thing what we know as a differential diagnosis to differentiate from the parapharyngeal abscess from the peritonsillar abscess is, here the entire tonsillar fossa itself is pushed medially. Okay, the tonsillar fossa is pushed medially. Okay, but in a peritonsillar abscess, what I said, in a peritonsillar abscess, it's only the tonsil alone is getting infected, not the parapharyngeal space. Here the entire tonsil is pushed medially along with the tonsillar fossa. So, that is the difference between a peritonsillar abscess and a parapharyngeal abscess. Do not confuse much. Okay, when they give a clinical scenario of a unilateral tonsillar enlargement, have in mind of a peritonsillar abscess. Okay. So, this is peritonsil abscess. So, coming on to the next question, next MCQ, all of the following are features of Menis disease except sensory neural hearing loss, idiopathic or endolymph pathology or radiofrequency ablation. What is the answer? We know that the Menis disease, what are the characteristics of Menis disease which we want to know? The patients present with episodic vertigo with the fluctuating sensory neural hearing loss, and how will be the sensory neural hearing loss? It is usually a low frequency SNHL in early stage. In early stage, it will be a low frequency sensory neural hearing loss. In a late stage, it can become normal. Say if this is the audiometry, in early stage, it will be a low frequency sensory neural hearing loss. Okay. As the disease progresses, it may turn into a straight line also. Okay. So, in early stage, it will be a low frequency sensory neural hearing loss. Along with that, there will be tinnitus, right, and there will be a oral fullness. These are the characteristic features in a Menis disease. So, episodic vertigo with the fluctuating sensory neural hearing loss along with the tinnitus and the oral fullness, right. So, all of the features except. So, low frequency sensory neural hearing loss, is it a feature of Menis? Obviously yes. So, it should not be the answer, it is true, it is not the answer. Okay. So, what are the, can it be idiopathic? So, what are the etiology of Menis disease? It is most commonly, there are lots of reasons. What is Menis disease? So, Menis disease is otherwise called as endolymphatic hydrops. So, here what happens? Here there is either increased, that means increased endolymph in circulation. Endolymphatic hydrops, that means increased endolymph in circulation. Okay. So, either there can be increased production of endolymph or decreased absorption of endolymph. These are the causes. Okay. So, it is Menis disease otherwise called as endolymphatic hydrops, right. So, going back, option C, endolymphatic pathology. So, this is true again. So, this is not the answer. So, what are the causes for this endolymphatic pathology? As I said, increased production or decreased absorption, right. So, it could be multiple reasons like either a viral etiology can be also a reason, but the most common reason is idiopathic. Idiopathic is the most common reason. So, again going back, so idiopathic is again true. So, this is not the answer. So, obviously the answer is option D, radiofrequency ablation is the treatment of choice. But again I will say, what is the treatment of Menis disease? Treatment of Menis disease is a medication what we give, but is there any surgical management for Menis disease? Yes. Okay. Yes, the surgical management is endolymphatic sac decompression. So, we are now dealing with the endolymphatic sac. So, the surgical management is nothing but a endolymphatic sac decompression is the surgical treatment of choice, first one. Okay. And radio frequency ablation or ultrasonic destruction, okay, can be tried, but it is not the ideal treatment. Okay. What are you doing? You are ablating the vestibular nerve. Okay. You are going and damaging the vestibular nerve. Is you are damaging, that is one of the treatment modality. Okay, but it is not the treatment of choice. So, the answer is option D. Okay. So, coming on to next question, question number 8. The protrusion of Adam's apple, a very easy one. What is Adam's apple? When we lift our neck, we can see the most projected one, that is Adam's apple. So, Adam's apple is the most projected one, right. So, Adam's apple is because of which cartilage? Just feel, because of which cartilage? This is thyroid cartilage, right. So, thyroid cartilage. Okay. So, the Adam's apple is because of which cartilage? Answer is A, the thyroid cartilage. So, both the lamina, the thyroid cartilage will have a superior lamina and the inferior lamina, and both these on both sides, okay, they will meet in the center point. The center point will have a projection that is called as Adam's apple. A very easy one. Obviously, I hope that most of your seniors would have got it, most of them who wrote the exam would have got it right. So, the answer is thyroid cartilage. Okay. So, coming on to the next question, Next question, office headache, again a easy one. These are one liners, these are repeated one liners which you should not spend more than 10 seconds to write this, to tick on this. So, office headache, a simple question, office headache is called as frontal sinusitis. Okay, this is a one liner. Okay, not to go much in depth of it, office headache is called as frontal sinusitis. Why it is called so? Normally what happens is a patient with the frontal sinusitis, when he is sleeping, okay, when there will be okay, what will happen is whenever he is in sleep he won't have any headache, and when he wakes up, okay, the fluid will try to come down, but it won't come down, right. We know that in a sinusitis, what happens in a sinusitis there is a blockage of the osteometal complex, right. So, this frontal sinus ostium is getting blocked. So, what happens? We know that the frontal sinus, for all the sinuses there will be some cilia, and the mucus secreting glands will be producing the mucus, right, and the mucus what it does, the mucus needs to come down, and needs to get drained in the ostium, right. So, what happens now? Initially, okay, so initially what will happen? So, initially say when the patient lies flat and is sleeping well, there won't be any problem. When the patient wakes up, what will happen? There will be some fluid getting collected here. The fluid tries to come out, but it won't come out, and it will be getting stagnated. Okay, so it will be getting stagnated. Okay, at one point, say when the patient goes to your office and say it's around some 12 o'clock or 1 o'clock kind of thing, at that time, okay, because of the fluid collection fully, the fluid will get collected fully, okay, and you will be feeling complete headache. Okay, you will be having some okay, you will be feeling a headache which will be very severe also, right. So, that is why the frontal sinus headache is called as office headache, a very important one. Office headache is called as frontal sinusitis, not much of a concept here. The reason is it will get stagnated and it will become peak at the lunch hours. So, the patient will feel that whenever he goes to office he is getting a headache, okay, that is called as office headache. Okay. Next MCQ, again a easy one, the most constant and the largest ethmoidal air cell. What is the answer? The most constant and the largest ethmoidal air cell. That means this air cell is present in everyone, and it is bigger also. What is that air cell? It is bulla ethmoidalis. The answer is it is bulla. So, bulla ethmoidalis is the most constant ethmoidal air cell which is present in everyone. Okay. So, for opening up the anterior ethmoidectomy while doing a surgery, we need to open up the bulla first. So, it is the most constant ethmoidal air cell which is present in everyone. So, we know that what is agar nasal cell? Option A, what is agar nasal? Agar nasal cell is the anterior ethmoidal air cell. Anterior ethmoidal air cell. Again, it is present in everyone. Anterior ethmoidal air cell is the agar nasal cell. Okay. So, anterior ethmoidal air cell, where it will be present? It will be present as a swelling just in front of the middle turbinate. Okay, it will be present in front of the middle turbinate. So, anterior ethmoidal cell present as a swelling in front of the middle turbinate is the agar nasal cell. Okay. So, what are the other air cells? So, again it is present, it is constant, but it is not the largest. So, it is not answer A. Okay. What are Haller cell and One OD cell? Again they are ethmoidal air cells, but Haller cell I am drawing orbit here. Okay, Haller cell is a very important MCQ. Haller cell is nothing but it is a air cell, it is a anterior ethmoidal air cell which is present just in front of the just below the orbit. Okay, Haller cell. So, Haller cell, anterior ethmoidal cell present just below the orbit. So, what is the significance? If I am doing a fist surgery, okay, and if I blindly injure that Haller cell, if I blindly open the Haller cell, I may injure the orbit. So, a repeated MCQ, Haller cell, anterior ethmoidal cell lies in close relation with the orbit. Okay. So, the other cells, so it is not option it is not Haller cell. So, what is Onodi cell? So, Onodi cell is a posterior ethmoidal cell which lies in close relation with the ON, have ON in mind. Onodi cell have this mnemonic of ON lies in close relation with the optic nerve, again a very important MCQ. Okay. So, Onodi cell, a posterior ethmoidal cell which lies in close relation with the optic nerve. Okay. So, the answer for this question is option B, the bulla ethmoidal, there is no doubt in it. For ruling out the other option, since they may ask the other option as a question, so I am just explaining it. Okay. Haller cell, Onodi cell very important. Haller cell, anterior ethmoidal cell which lies in close relation just in front of the orbit, just below the orbit. Onodi cell in relation with the optic nerve, posterior ethmoidal cells. Okay. So, coming on to the next question, right. The ideal investigation of choice for confirming CSF rhinorrhea. So, the investigation of choice, again a one liner. The investigation of choice for a CSF rhinorrhea is go on to the option A or B or C or D. Okay. Obviously A is used in diagnosis of CSF rhinorrhea. CT cysternogram is we are doing a lumbar puncture, we are giving a dye to the lumbar puncture and the dye goes in the CSF circulation and it comes through the nose and we are checking through it. Obviously, this is also used for confirming. The nasal endoscope is also used for confirming we are passing endoscope and we will give a Valsalva to check the site of leak, again it is used for confirming CSF rhinorrhea. The MRI with contrast can also be tried, okay, for confirming CSF rhinorrhea, but what is the ideal investigation of choice to confirm it as a CSF rhinorrhea? It is a beta 2 transferrin analysis. Okay. So, beta 2 transferrin protein, it is a protein which is present only in CSF, not in any other conditions. Okay. A CT cysternogram we can even miss it with the CT cysternogram, but if we are taking the fluid, CSF rhinorrhea fluid, ask him to blend, collect in a test tube and send it for analysis. Okay, the beta 2 transferrin analysis is the ideal investigation of choice for confirming CSF rhinorrhea. Right. So, coming on to the next question. Okay, now it is a case based. A 30-year-old female, she met with a road traffic accident, she did not wear her helmet, leave out the stories and all, she had loss of consciousness for some time, leave out the stories again. So, while giving the clinical scenario, if you have time, read everything, or if you do not have time, just go on to the last line. She rushed to ENT department complaining clear fluid discharge from the nose. What could be the diagnosis? Okay, so she had a road traffic accident, okay, she had a loss of consciousness, LOC for some time, okay, and then she became normal, she left home. After 2 days, she rushed to ENT department complaining clear fluid discharge from the nose. What could be the diagnosis? Clear fluid discharge from the nose. Clear fluid discharge from the nose indicates that there is a no infection and there should be a leak of water kind of thing. So, what is a watery discharge? It should be CSF. So, the answer is again a very easy one. The answer is CSF rhinorrhea. Can it be allergic rhinitis? Okay. Why should the allergic rhinitis? It can be allergic rhinitis, a clear fluid. The patient may sometimes say that it is something watery, but it may be sticky also. But why should the patient present to you after a road traffic accident with allergic rhinitis? So, the answer is option not A. Okay. Infection due to hemosinus because of road traffic accident. Okay. If there is an infection, what will happen? Infection, then the character of discharge, it will be turned into a purulent discharge, it will be a pustine discharge or a mucopurulent discharge, right. So, obviously, it is not the option. Post traumatic rhinitis, okay, and I do not feel any terminology like a post traumatic rhinitis is there, okay. There can be a fear induced rhinitis, okay. There can be a post traumatic some other disorder, maybe a psychiatric disorder, but post traumatic rhinitis is not a again post traumatic rhinitis is not the correct terminology to use. The answer what has been mentioned here is the ideal thing is post road traffic accident, the patient is present with a clear fluid discharge, think of a CSF rhinorrhea. So, this is the answer. So, fine. So, these were the questions asked in previous year, fine. Previous year December FMGE questions, okay. And as I say, there will be repeaters, there will be one liners, so it is a must for you to just rush up through the basic one liners for your in your ENT and what all the other subjects also. ENT alone will carry some 10 to 15 questions which are important for you. All the best for your exams. Thank you.